Minnesota is one of the healthiest states in the country. This status was achieved by assuring that most people in Minnesota have health insurance, that the cost of health care is affordable, that everyone has access to food, that abused children are protected, that the elderly are cared for, and that the needs of people with disabilities, mental illnesses, and substance abuse are well addressed. Most of the efforts in each of these areas, and many more, are led by the Minnesota Department of Human Services, the state's largest agency, serving over 1 million Minnesotans in 87 counties and in 11 tribes. We'll be discussing the roles and activities of the Department of Human Services on today's episode of A Public Health Journal. Please stay tuned.
Welcome to A Public Health Journal, a program that explores public health issues facing our society today and tomorrow. The host of the show is Dr. Ed Ellinger, Commissioner of Health for the state of Minnesota. A Public Health Journal is sponsored by the Minnesota Department of Health and the Hennepin County Human Services and Public Health Department, all working together towards the goal of healthy people living in healthy communities.
Welcome to A Public Health Journal. Today we're going to look at some of the activities of the Minnesota Department of Human Services that help protect and improve the health of all Minnesotans. The Department of Health and Human Services, or DHS, is the largest state agency with a portfolio that includes Medicaid, Minnesota Care, long-term care, mental health, substance abuse, food stamps, and many more. DHS works in all of Minnesota's 87 counties and with all of the 11 tribes in the state. Joining me in this discussion is Lucinda Jesson, Commissioner of the Department of Human Services. Cindy, welcome to our program.
I'm just delighted to be here, Ed.
Well, it's good. I'm kind of going through the various commissioners, and certainly Department of Human Services is one of our Department of Health's great partners in improving health. So it's good to have you on. And I know, like I said in the introduction, DHS is the largest state agency, and we'll be talking about just a few things that DHS does. But maybe you could start out by sort of giving us that elevator speech. What does DHS do, if you describe it to somebody who really doesn't know the Department of Human Services?
Well, I think almost every family in Minnesota at some point in their life needs help. Maybe that because someone lost a job, or they have a health care need, or a family member with mental illness or substance abuse problems. And at those times of need, our department's there to help people. You know, our department touches over 1 million Minnesotans every year. If you think about it, we only have 5.3 million people in Minnesota. So that's, about almost 1 in 5 Minnesotans. We help them with health care when they need it. We provide services for people with disabilities, for the elderly, for people with mental health and substance abuse problems. We do a lot for kids. We have this year over 500,000 Minnesotans on SNAP, on our food assistance programs, because in this really hard recession, a lot of families, working families, need help just to put food on their table. So health care, food, making sure children are safe, especially those foster children and other children in our child welfare system. Same for adults, making sure that we have the adult protections for the elderly and the most vulnerable. Those are just some of the things that we do, Ed. It's kind of overwhelming some days, it feels like, but mostly it's just a wonderful opportunity to help people at those times in their lives when they really need that hand up.
Mm-hmm. Yeah, you really deal with a lot of the most vulnerable populations within the state. As you say, the elderly and the poor and the people with special needs and the mentally ill.
But Ed, the people we help, it's not some other group. It's not just them. If you think about it, about 1 in 5 Minnesotans, most of us in our families at one point or another have needed the help from the Department of Human Services. Maybe just to make sure that we have child care for someone in our family, or to get something as simple as that. But I think it touches almost everyone.
Yeah, and that's the three things that we're going to talk about today really are something that all of us will have to address at some point in time. Long-term care, as we get an aging population, substance abuse, which affects really every family in this community, and health reform. So let's start talking first about long-term care. And I know you've got a program, and I know you're working with the Lieutenant Governor on Own Your Own Future. Tell us a little bit about this project.
Well, Ed, most of us in our lives are going to need some sort of long-term care. By the time 70% of us after 65 are going to need long-term care at some point. Now, but long-term care isn't, most people when they think of that, they think, oh, it's about a nursing home. But most of us, when we need long-term care, it's not going to be necessarily a nursing home. It may be someone coming in helping with chore service, a visiting nurse, PCA services, personal care attendant. but especially as we get older, people in their 80s and 90s, and we're living longer, which is a good thing because we're healthier.
Yeah. Well, actually, I have a slide. Let me put the slide on as you're talking about this. Which shows sort of the number of elderly that are going to be in the society, and by 2045, we're going to have over 600,000 people who are over the age of 85. That's a huge number.
It's a huge number. Think about it this way. Baby boomers last year started turning 65. Well, in 20 years, they start turning 85. And a lot of those people are going to start needing some sort of help in long-term care. The reason we started this campaign, Own Your Own Future, was because most people don't believe they're going to need long-term care. Maybe we're too optimistic, but most people my age, 54, they don't see themselves ever needing long-term care, and they haven't planned for it. And so this campaign, the beginning part of it, is just to let people know you're going to probably need it. So let's make a plan. Let's make a plan for how you want to live those years. Talk to your family. Get some help. Have a financial plan, but also have a plan about what choices you want made towards the end of your lives. Talk to your kids about it. Talk to your family.
Well, and we also have, you talk about, financing it. We do have a slide here that shows right now who pays for long-term care. And you can see that Medicaid and Medicare really pay for about 2/3 of it, out of pocket about 25%, and a very small amount for private insurance. I think most people say, well, somebody's going to cover it, or I'll have enough resources, but it's pretty expensive, and Medicare and Medicaid can't cover it all.
Well, that's right. But a lot of people, if they think about long-term care, they assume Medicare is going to pay for it, and they're going to have Medicare, right? Well, but Medicare doesn't pay for most long-term care. It pays for like a nursing home visit. It pays for maybe the first 100 days, maybe. So beyond that, for someone who needs extensive long-term care, their choices are paying for it out of pocket, or having to really spin down, basically financially make themselves destitute to qualify for Medicaid. Those aren't good choices. And for a lot of people, Medicaid is a really important program. It needs to be there for the poor and people who need it. But it shouldn't be our default long-term care insurance plan. And I think if most Minnesotans plan for it, we'll be able to maintain a successful Medicaid program for people who need it. But that shouldn't be people like me, frankly.
Are you getting much traction with I know you're going around the state talking about it. I know the lieutenant governor is really talking about this. Are people resonating with this, like, oh, we better pay attention?
Well, we've been tracking we have this new website, which we'd love people to go to, and it's not just talking about the need to plan, but giving people tools, a checklist depending on their age. And we're having a lot of people go to that website and spend some time on it, which we are very encouraged by. And we're starting to work with a lot of employers around the state, asking them to help get information about this new planning tool to people. So we really are doing everything we can to get the word out.
Right. And I know that the Twin Cities Medical Society is doing something called Honoring Choices, which also looks at end-of-life planning and making sure you have advanced directives. So it sounds like a lot of things are coming together now to say, let's baby boomers and people following after that, do some planning.
That's exactly right. And actually, some of the folks on the Honoring Choices program are part of our advisory panel that the Lieutenant Governor and I are heading on the Own Your Own Future, because they really are intersecting. It's planning for the choices, planning financially, even simple things like, if you are my age and thinking, well, am I going to sell my house, or do I want to stay in my house? If you want to stay in your house, think about the modifications you may want to make so that you can stay there.
Yeah. Well, there's a lot more we could talk about, but we need to take a little break, and then we'll come back and talk about another subject.
Okay.
So we'll be back right after this message.
We got the spirit, we're hot, we can't be stopped. We got the spirit, we're hot, we can't be stopped. We're gonna beat them and bust them.
The smallest moments can have the biggest impact on a child's life.
Let's get a little bit rowdy, R-O-W-D-Y.
Take time to be a dad today. Call or visit fatherhood.gov to learn more.
Welcome back. We're talking about some of the services from the Department of Human Services with Minnesota's Commissioner of Human Services, Lucinda Jesson. Cindy, we briefly went over long-term care, but now we have another big problem, or big issue, I think, that your agency deals with, and my agency, and a lot of agencies, and that's substance abuse. Tell us what's your role, what the department's role is in substance abuse in Minnesota.
Well, DHS is designated as the Substance Abuse Authority for the state of Minnesota. So that means we have some responsibility, but we work with a lot of folks around the state to try and address substance abuse, which is a huge problem for Minnesota. If you think about it, one of the reasons our health rankings overall have gone down is because we have the binge drinking problem. And we now know that we have an increasing problem with illegal use of prescription drugs and heroin. So from the department, we have two main things we try and do about it. One, we do provide dollars through our treatment fund for treatment, especially because there are a lot of people who may have health insurance, but it doesn't cover substance abuse very well. But we also do a lot of the prevention front, working with counties and a lot of nonprofits in the Department of Health. But this year, as we were looking at substance abuse, we thought, we work on substance abuse issues. So does the Department of Health. So does the Department of Education, the Department of Corrections, Department of Public Safety. Wouldn't we all do a better job tackling what is really a key issue for Minnesotans if we all came together? And we're all working towards those same goals, and we were aligned. And that's why we, just this year, we're the first state in the country to say we're going to have a statewide substance abuse strategy where we're working across the administration on the same goals on this huge problem. So it's really been a great effort that I think we're starting together.
Right. Well, and I know as part of that plan was really looking at the data. And we've got a slide here that shows, and you mentioned this sort of what's going on with the opiates and heroin kind of thing, which I think people really be shocked at. So maybe you could explain a little bit about what this slide is saying.
Well, one of the things that we identified in our report as an immediate thing we needed to tackle was the problem with the increase in heroin use and illegal use of prescription drugs. We've seen some other drugs at least level off, like meth. We knew we had a problem. We still have a problem with meth, but at least we're not seeing the dramatic increases. But here we are. What these slides show you are just the admissions, treatment admissions. Like in our hospital, people are coming to our hospitals because of problems with heroin. You see dramatic increases. And with other opiates, those are like what might be when prescribed, appropriate legal prescription drugs, but when they're being sold and they're not prescribed, things like Vicodin, then those are what kind of come in the categories of other opiates. And we're seeing a lot more people admitted because of problems with these drugs. And what concerns me, frankly, Ed, these are the numbers of people who are admitted for treatment. What worries me are all those folks out there that aren't admitted for treatment, and we know there are a lot. So this is a big problem for Minnesota.
Well, it's also interesting that the heroin really seems to be a metro problem. The prescription opiates are a problem both in metro and rural. So tell us a little bit about what's going on with prescription drug abuse. We're hearing a lot about this. It must be a huge problem for your agency, and certainly it is for the state.
It is, and I think we need to work very closely with the medical community, particularly to look at this issue. I think that there's this perception that they must not be that harmful because, after all, these are prescription drugs, right? And one of the things that's most troubling to me when we look at how do the kids, because there are a lot of problems with like 12th graders. We did a survey of 12th graders. How do they get those prescription drugs they're illegally using? Most of them, they were given them. They weren't buying them. Sometimes that happens. They took them from someone's medicine cabinets that weren't used, or they got them from a friend who did the same thing. So it's a real concern, and we see that as those illegal use of prescription drugs really is a gateway to heroin, and that we see people start with those and then progress to heroin. When I talk to parents in, for example, in suburbs, they don't think heroin could be a problem in their community. Isn't that some sort of kind of inner city or somebody else's problem? Let me tell you, it's there.
Well, and I know you had talked, or in my introduction said that you work in 87 counties and in 11 tribes, and I know a couple of the tribes have declared prescription drug misuse as a public health emergency. So they must be feeling the impact and also taking a lead in making things happen.
They are, and we're also working closely with law enforcement about this as well. And we've seen, like, in heroin arrest, more than double, just in 1 year. But I think that there's also a lot of good work, as you mentioned, with the tribes and others to try and come together to address these problems. Working, one of the things we really would like to do is have kind of our prescription drug monitoring program become more than voluntary, so that when someone goes in, so we do have drug seekers out there, so when they go to a doctor in the clinic or in the emergency room, that physician has access to know kind of like, oh, is this person going to a number of other places seeking that drug as well? So I think there's things that we're really trying to beef up, working together to get this problem under control. But part of it is really public education, which is why I'm so glad that we're able to talk about this on the show today.
Right. I know we're going around the state talking about this, and there certainly is a lot of interest throughout the state. What are some of the things that local communities can do to, deal with all sorts of drug abuse? Certainly alcohol continues to be the number one, drug abuse problem in our state, and now the heroin and opiates. What can local communities do? And I know you've got some workforces, some task forces, some work groups looking at throughout the state what's going on. What are some of the recommendations that can come from that?
Well, Ed, you and I have been actually out there together talking to local communities, and I think one of the things that I've learned, taken away from that, is that we really need a local approach. The state should be there to help and to guide, but like when we were up in Duluth and talking to them about what are some of their big problems, synthetic drugs, big problem in Duluth. We were going over in Bemidji, not as big a problem there. But there, some of the methadone was illegal use of methadone was a real problem there, though there's some of that in Duluth as well. So I think what the message I got talking to people was they needed to be working together. That one of the biggest things was coordination. That in communities where you have law enforcement working closely with public health and with education in the schools and with the child welfare system, and they're all they're looking at the problem and at the people who are suffering from that, not kind of each from their own silo, but working together, that you see a lot more improvement.
Yeah, and it certainly reflects the fact that this is something where we need to work on prevention. Law enforcement is really important, intervention is important, treatment is important, but we really need to go upstream on this because it's probably a big thing in your budget. If we reduce the number of treatment programs that are needed, would help the budget quite a bit.
I think it's a big thing for a state government's budget overall. There's a recent study that said that 15% of what state government pays for is attributable to substance abuse. Think about that. Because if you think about it, people who aren't getting the treatment and the early intervention, they end up disproportionately in our prisons, some in our mental health systems. I mean, they're not doing as well in our educational system, and that's more costly. And obviously then ultimately they end up in our public safety system.
Yeah, big problem. Well, we'll go on to another one, health reform, but first we need to take another little break. We'll be back right after this message.
For those dealing with the daily struggles of caring for a loved one, we hear you. That's why AARP created a community with experts and other caregivers to help us better care for ourselves and the ones we love.
Welcome back. We're talking with Lucinda Jesson, the Commissioner of the Minnesota Department of Human Services, about a variety of issues, but right now we're going to talk about health reform, which Commissioner Jesson has been leading as part of the Dayton administration work on improving our healthcare system. So Cindy, give us a little background of health reform in Minnesota. And we've been doing this for a long time, and then it's sort of bubbling up to now in 2012, 2013, some big decisions have to be made. So maybe a little background.
We have been doing health reform in Minnesota for a long time. I was at the Children's Defense Fund yesterday and telling the story of a nun from the Order of St. Benedict in the early 1900s who was up in the selling tickets to lumberjacks. Tickets about 50 cents to $5 a piece, and that ticket would entitle you to 6 hospitalization stays at one of St. Mary's hospitals. We were one of the first places in the country that did that. And actually, while people think health reform, they think of the Affordable Care Act or Obamacare. A lot of the Affordable Care Act was really actually taken from or building on stuff we've been doing in Minnesota for years. But the Affordable Care Act does give us some additional federal dollars and opportunities to do what we were doing already faster. So I think, two of the big issues that are going to be before the legislature this next session are going to be kind of fall from that. One is, do we do a state-based health exchange instead of, or do we default to the federal one? And second, do we expand Medicaid, another state choice? So those are two big issues that will be in the headlines, but I think below that, we've just got to keep doing the work Minnesotans been doing forever. We need to do a better job with prevention, keeping people healthy so they don't need that crisis care to begin with. We need to do a better job, frankly, controlling costs. Because if we don't keep going down that path, this all just becomes unaffordable pretty quickly. And finally, Minnesota historically is a high-quality, relatively low-cost state, and we have to focus on that quality too. So I think part of that is just changing the way we pay for health care, where we give the incentives. The incentives are to keep people healthy, to intervene earlier, instead of making the financial incentives just to treat people when they're sick. So that's the stuff that doesn't get the headlines. But that's where I think a lot of our great healthcare industry and providers and advocates are working on today in Minnesota.
I know when the ACA got passed, or Obamacare, one of the big things was, we have 50 million people nationally who don't have insurance. Minnesota has done a much better job of getting people insured, but our numbers of uninsured have been going up over the last few years during the bad economy. How will the health reform, deal with that 9, 10, 11% uninsured in Minnesota?
Well, right now I think we have about 9.1% of Minnesotans who do not have health insurance. After the full implementation of the ACA, we project that by 2015, that number will be cut in half. Only 4.2% of Minnesotans will lack health insurance. Now, health insurance in and of itself doesn't solve every problem, but still, that's a dramatic difference. Though, of course, what you and I will do is try and figure out then, well, what do we do to that with that 4.2%?
Right. The other thing is, is cost. What is being done in this state to really start to focus on the cost? And again, we've done a much better job than most other places. Costs of healthcare here are lower, but what more is being done, and what are some of the recommendations that will be coming from the task forces that are working on this?
Well, I think the two big themes that we've been working on in Minnesota and that the task force recommendations are going to urge that we push faster are, one, change the incentives. The incentives need to be changed, the financial incentives, from treating people when they're ill to keeping people healthy, so that we're really paying for health instead of just for sickness. And the second thing, which is very tied to that, is we need integration. Right now, we have these different silos, kind of reflected in the structure of my agency sometimes. We have kind of more the acute healthcare side and silo, and then the long-term care silo, and the mental health silo, and the social services silo, and the substance abuse silo. Now the incentives are, well, get them into somebody else's silo. And that doesn't help people shifting from one system to another, and it doesn't help control costs. So we really are pushing integration. And, it doesn't happen overnight. It's not going to happen quickly. But we've, seen some real progress with things like Hennepin Health. What they're doing here in Hennepin County was one of DHS's kind of work with Hennepin to try and kind of integrate the social service and the chemical dependency with our healthcare system. So change incentives, integrate.
All right. And how about the prevention piece? Certainly my agency does a lot with trying to move upstream. How is that being built into some of the things? I know part of the ACO model and some of the changing reimbursement saying you need to focus upstream on some of the prevention things.
Well, if you're paying to keep people healthy, what that's doing is saying, okay, if you're going to pay to keep people healthy, you have to do prevention. You have to do early intervention. So when I talk about changing the financial incentives, we want to make it, to change those incentives so that providers are working with communities to do that early on, and a lot of them are doing it because it's the right thing to do. But when you also make it the financially best thing to do, I think you get people to move there more quickly. And integration is really trying to push kind of our traditional medical community to integrate with the public health and the social services side, where they focus a whole lot more on prevention than, frankly, we do in our traditional medical community.
Right. I have one last question. This is a tough question. Given all of the stuff in your agency, why did you become Commissioner of Human Services?
It is, you can look at all of these things as problems or just opportunities to help people. Yeah. And there are a lot of opportunities to help people, and we live in a great state to do that.
Right. Well, that's why it's fun to work with you. We had some great opportunities to work together on. So thanks for being with us.
Thank you so much.
And I'll be back with a closing comment right after this message.
Good news, everybody. People are living longer than ever before, which means most of us can look forward to more years doing the things we enjoy, if we plan ahead. That's because, at some point, the vast majority of older Americans are going to face a physical or mental disability, and they're going to need some help. In fact, there are more and more young people who face the same challenges, which costs money, and health insurance and Medicare don't always cover it. That's why it's so important to make a plan, and to address a few key questions. First, do you want family or friends to take care of you? And are they willing to do it? Do you want to stay in your home? If so, does it have a bedroom, bathroom, and kitchen on the same floor? How about in-home care, assisted living, or a nursing home? How much is it going to cost, and how are you going to pay for it? And of course, what are your preferences regarding end-of-life issues? Have you written them down? Yes, these are complicated questions, but not to worry. This website has everything you need to make informed decisions. So look around. It'll help make those bonus years the best they can be.
One's health is determined by multiple factors. Certainly one's genetic makeup is important, along with access to high-quality medical care. But other factors are also important. Things like one's environment, social and economic circumstances, and individual behaviors. As I look around this country and around the world, I've noticed that the places where people are the healthiest are the places where all of these health-determining factors are addressed in a comprehensive and collaborative fashion, not in an individual or isolated fashion. Places where people are the healthiest have effectively integrated medical care services with public health and social services, and have delivered these integrated services in an educational, physical, and social environment that supports health. Minnesota is one of the healthiest states in the country because we have also done a good job of integrating medical care, public health, and social services in a unique and effective way. The interactions between the Minnesota Departments of Health and Human Services are a great model of this. Certainly there is more that can be done, but the interactions of these two agencies, along with many other state and community partners, are a good example of what the Institute of Medicine meant when it defined public health as what we, as a society, do collectively to assure the conditions in which people can be healthy. Optimal health for our state will not occur if we only work within our organization, agency, or special area of interest. Minnesota can become one of the healthiest places in the world only if we all work collectively to assure the conditions in which all Minnesotans can be healthy. That's all for today. Thanks for watching. I hope you can join us again next time on A Public Health Journal.